All right, Andy's up. All right, come on over here. Do you remember Janice?
Yes.
You remember Janice? So she's 33-year-old. She was previously pregnant. You helped her through that. You know her very well. She got PPE. Baby's still doing fine. In fact, the baby is no longer in NICU. Baby is gone home.
Nice.
Baby's doing fine. She went through. Janice went to the floor very briefly. Got septic. Came back. Where they've gone from there is they went through with the help of ID. They got some scans. Everything was clean. Sides look fine. Ultimately, it was determined to be a line infection, so that line has been exchanged. So she now has a left IJ. She still has the art line that was placed when you all came in, and since then she's still been in the ICU for the last couple of days. She's been getting markedly better over the past. She's been here now the last 4 days. She's been steadily getting better from a hypotensive perspective. Still on the antibiotics. They ultimately decided to go with the vancomycin, and she was on Norepi up until, say, this morning. She finally was able to come off early this morning, about 4 a.m. They were able to switch it off. Has not had to go back on to pressor since then. But the one thing you're called for is nursing staff comes to get you and tells you, like, she's been on 2 liters nasal cannula 24 hours ago, and then, yesterday, just before we started, we noticed she was on 4, and then just throughout the night, I've been steadily coming up. It's one of those things. You've been here for 10 hours, and they finally just come tell you that, oh yeah, like, those sats have been the same, and maybe you got busy, you hadn't noticed, but they've come from 4 liters to 10 liters now, and now they're coming to tell you, like, oh yeah, I'm just charting, I'm just letting you know that I'm now come from 4 to 10 liters, and we're 87%.
These people. What's going on, Miss Janice? You're still here.
Oh, hi.
So what's going on?
I don't know. What's going on? I'm doing okay.
Your oxygen's a little low, so they called me in to come and see you again. Are you feeling?
Is it?
Yeah, it's like 87 right now.
Oh, is that good?
Yeah, can we put on an elbow?
Yeah.
I don't know. We do like 30 liters, 60%.
Stay
see what happens.
airflow, is that what you said? Okay.
Airboat?
Are you feeling short of breath?
A little bit, yeah.
Okay. Any coughing, speed in production?
No, not really. I mean, a little bit of a cough, but that's always been there.
Okay, but you're not coughing anything up, right?
No.
Any fevers?
No.
And do you have any like chest pain when you breathe in or breathe out?
No, not really.
Okay.
You said 30 liters and...
I would do like 50%.
50?
Yeah, to start off with and see what happens. Can we do an ABG2 and a chest x-ray?
Try your ABG.
What else can we do? Turn on Lovenox, shortness of breath. Let me get the ultrasound. Okay, not much to it. Alright. Ms. Janice, I'm gonna ultrasound your chest again. Just kind of see what's going on. Vitals are fine. Let's go up a little bit. Yeah, it's compressed. Oh, I put it in there. I got it.
Yep.
When did this shortness of breath start?
I've been feeling short of breath all day.
All day, but just started today? You weren't really feeling this yesterday?
A little bit yesterday too.
Okay. Let me see any effusions. So it's pretty collapsible. I'm going to look at the lungs. Okay. So, I mean, her RV didn't look dilated to me. Yeah, she looked like maybe a little hyperdynamic. But at least she's flexible. I don't think really she was volume movement over there. Like, it's all good lung sliding, so not like a pneumothorax or anything like that. My gas, it's only, I mean, she's like talking to me for a second. That doesn't look like too terrible. What is she siding now on the Airbo?
84.
Yeah, you know, let's put her 60 liters 100% and see what happens. And she has an A-line, right?
Yeah, should I on the left hand side? We changed our airboat to 60 liters and 100%.
I'm going to start high and whittle it down. This is too much thinking after lunch. Did you get the X-ray back?
Just X-rays.
This is not good. No. No, it's the words.
That's pretty bad.
I have the classified angle. It just kind of looks like diffuse interstitial opacities. Touching cross and tracheal midline. I mean, it looks like she's kind of going hard here. So. Now, I don't want to diurese her because she already looks super collapsible on ultrasound. And she's on 100% at 60, she's still signing 85. I mean, you could try that, but I don't think this is like a thing that's going to be fixed like fast, right? So probably not the best option. I don't know if we should go ahead and intubate her because of what her lungs look like. But I mean, she's 87. I mean, that's not like a super terrible sat with ours. She's not really hypercapnic. Anybody have any thoughts? Speak up if there
I
is a
think
piece.
eventually you're going to be pushed in the direction where you have to intubate her.
Yeah.
Like, I feel like her oxygenation isn't going to get any better.
Can we do a repeat gas with her current thermometer settings?
I agree with the, it doesn't seem like she has any like cardiac deficits or doesn't seem like overloaded. So then I would call that like non-cardiogenic pulmonary edema essentially. So I mean, I don't think that's going to improve short term. And but she had a COVID test recently, I guess.
I mean, she's been in the hospital. I mean, we could redo one, but
Maybe you can get it in the hospital.
yeah, we could do another COVID test. I mean, it did go up,
But I think like
it went up.
right now
It went up by
she's
two.
like toxic.
2 numbers. I don't think that we call that improvement. Okay, so we can repeat a COVID test. She's not really febrile, so I don't necessarily know that it's infectious. Now I think we need to do a CAT scan. I mean, I think the source is kind of pretty obvious with the hypo. Has she tried self-running? I mean, do we think that could help? But how far out is her surgery?
We're pushing 3 weeks, 3-4 weeks now.
Yeah, she can lay out her stomach though.
Yeah, I mean, we could try that and see if that improves her oxygenation. Can you do flow line on air though? I don't remember.
I don't think so.
I mean, we can do it on some stuff. But I don't.
You could buy that?
I think they did do it on like heated high flow and 5E, I think.
Can you do nitric oxide on air though?
I don't think nitric oxide.
They could do
I think
flow.
they did like the.
I mean, if we could do it, I would try. I would see if she could self-prone. Do you think you could lay on your stomach for a little bit and see, because that might improve your oxygenation.
I can try it.
Should we actually put that?
So she's gonna self-run. She can do it herself. So.
And then if we can, I would call our team see if maybe flow land through the what am I looking? The word I'm looking for? Airva?
Perfect.
So this is her self-proned.
Okay, she's self-proning. I would call her routine still ask about the fluid to see if it's possible. I would also do another gas while she's self-prone from the A-line and see what her oxygenation is there. Because I mean, were the stats correlating? I mean, I'm assuming they were from the gas to the monitor. So maybe I don't really need to do another ABG, to be honest with you. She's 91%. I would have her self-prone. Anything else you want to do? I'm a little lost. I mean, it's arts, right? So part of this is going to be, unless we think it's infectious, like I'm not going to give her any antibiotics.
Yeah, I mean, like, why do we think her chest X-ray looks like that? Do you want any other labs?
I mean, we'll do a CBC, a BMP, get her a whole set of rainbows. I don't know. I mean, a D-dimer wouldn't really be any benefit. I don't feel like she's comfortable to really go down for a CAT scan to do like better imaging of the lungs right now. She's not really coughing. You're not coughing anything up, are you?
She has a dry cough occasionally, but nothing's left.
I mean, if she coughs something up, it could be sputum cultures, but if she's not coughing anything up, I'm going to be too. Does your shortness of breath feel better, a little bit better now that you're laying on your stomach?
I don't know.
You don't know?
Has she already completed her antibiotics for the bacteremia that or she's still on the same? Okay. So she still should be covered.
Yeah. I mean, I don't see any signs of like active infection unless she's, like she's not febrile, unless her white cells are like super elevated. Am I missing something? I feel like.
Well, I guess my question is like, why does she have ARDS? Like, why does she have all these coagulopathies on her chest X-ray? It's not like a cardiogenic cause.
And she didn't recently get blood or anything.
She has, but not recently.
So like, how recently did she get blood?
Last time she got a unit was maybe 3-4 days ago.
Okay. So that's not like an acute lung injury from that. How's that fun?
Now she's having 88%.
I mean, I'm okay with her being, with ours, I'm okay with her being like high 80s, like some method stuff that. Are you feeling better or worse? Or the same?
Not the same.
Okay. Let's move.
She's an anion-gabnet acidosis too. I don't know what's driving, but maybe lactate.
Yeah, so let's throw in a lactate. What, a 2.12? I mean, that's not super terrible.
PUN's not that high. Big ketone.
Okay, so she's 86. If your oxygenation continues to get worse, I think we are going to maybe have to put you on the ventilator to kind of help support you. How's her breathing look? Is she like super labored?
And she's tachypnic. She's part of the labor, but she's. I mean, you can definitely see she's using extra muscles a little bit more and more.
So how do you feel about if you need to go on the ventilator? Are you okay with that?
Oh dear, I don't know.
Did we ever talk to respiratory about starting the flow land?
Oh, no, I'll call them. Can we put flow in your interval?
That's a question I wanted to ask.
Okay, we
Alright,
can.
I would try it.
Okay, I'll rush through it. I'm hooking up the slow now.
Let's call anesthesia too.
Okay.
Just in case we need to go intubation route, they can get into it. I'd rather us try to intubate her. The problem is that your oxygenation keeps dropping, but your heart rate and your blood pressure. But I think that, we might have to, that might be something we have to do if your oxygenation keeps dropping.
Oh dear, oh no.
Yeah, so Richard, can you call anesthesia?
Yeah.
And let them know that we're probably going to need to intubate.
Anesthesia. Oh. Perfect.
I'm anesthesia.
What's her blood sugar's 104? She doesn't have a history of diabetes or anything like that, right? She's in the hospital, so I doubt she's been exposed to toxins. Has she been taking aspirin? I think I do a salicylate level. I'm just trying to figure out reasons why she has an increase in that. How's her PO intake been?
Yeah.
So not like a starvation ketosis.
Yeah.
Okay, I'm with anesthesia.
Hey, so this is Miss Jackson. Looks like on chest X-ray, it looks like she might have some acute, some ARDS. She had a complicated stay. She's a statin kind of 84. We tried to self-prone her. That improved a little bit, but she's been found drumming. We started her on some Flolan. Hasn't really, her stats increased initially and responded, but now she's kind of back down to 84. So we were talking about it, and I think we kind of want to go ahead. She's working a little bit to breathe, to go ahead and kind of intubate her while she's, relatively stable-ish, and then kind of continue, trying to work up this hypoxia.
Okay. She's setting now. Okay.
She's
Can we-
setting 84.
Yeah.
Can we get Levo hanging and on the pump at the bedside, and then a stick of epi, 50 of rock, and
What access do we have?
yeah, what else do we have?
Let's see, we've got a 18 in the tent over here. Looks like a 22 in the arm with.
There should be a lift idea as well.
And there's stuff. And that IJ's in good position.
And then 20 of atomate, are you familiar with the dosing?
Yeah. I think most of the time it's 20.
20 of atomate, 50 of rock.
You want to give those back?
Yep.
Richard? Thank you.
And then we have our Levo hanging and in.
Connected, it's not going in, but it's
Okay.
connected. We have a media stick.
And then
It's programmed in, it's for you to do.
can we grab a stick of epi too?
Yeah.
No, atomate rock, epi stick. That was it.
I mean, she was pretty collapsible. Could we give her some fluids? I mean, Max fine. I don't think she.
Yeah, we can also start some fluids and just have them flowing for while we're intubating.
Do you want to start put a mask on her so
Yeah.
the oxygen anymore?
Or did you hook up the fluid line?
No, no. We're going to play 500 bolus.
Oh, that's the bolus.
Do you want to do a little?
Alright, here.
I don't know if she's trying to blood pressure good, but she's pretty collapsible on the ultrasound.
Yeah.
Can I have Richard, do you mind? Or Andy, somebody. Could somebody come over here and just kind of hand me things
Yeah.
and lower the bed?
Alright, so we got fluid hooked up. We got Levo, it looks like, hooked up.
Alright, dear. Take some deep breaths. Go ahead and give the 20 at a
Hold
time.
on, before I forget, so
Yeah.
let's make sure we got everything going on there. You got your suction. Do you have an oral airway?
I do.
Okay. You got your ET tube.
Yep. Right here.
Yep. Our stats are going up. I would kind of see if they, and at least like we're kind of in the 90s usually into data. And she's responding, so I'm just kind of.
I don't think we've pushed anything yet.
No. Let me know.
Ready?
Your call. Yeah,
Okay.
anesthesia.
Go ahead and push the accommodate.
Okay.
20 to accommodate.
Alright. Bring it accommodate.
Alright. Yeah. Go ahead and push the rock.
Okay. How much rock?
50 of rock?
Yeah, 50 of rock.
Here, you want me to bag on
Yeah, I
you?
feel bad. That'd be great.
That's it. 99%.
Alright. Ready?
No, never.
You pull the toilet.
You want me to do this?
Will you listen, Richard?
Yep.
Do you see consolidation on the ET tube? We have good
Yes, sir.
title change.
Yeah, color change.
And we have good lung sounds.
And
Turn on the vent.
I guess we can hook up an end title now too.
Yeah. I'm not bugging around with them. Let's see if their stats come up. Is it easy to bag?
Is she easy to bag?
Not easy, but it's not.
Not terribly difficult.
What setting am I putting on the vent here?
I do AC. I'll do a rate of like, I'll do a rate of 16 tidal volumes. I'll do like 400. I'll do five repeats and 100% of tidal too. For now. And we'll recheck the gas pretty quickly after. And the next ray to confirm placement. And this one like GG. And then let's hook up the flow in through the vent. So that works.
Alright, so flow in through the vent.
Alright, what else should we do? I mean, she's still 70, 88, right? What are repeat pressures?
48.
You wanna ultrasound her?
What's our plateau pressure?
Plateaus?
Yeah.
33.
Let me just ultrasound the lungs again.
What are you looking for?
I was just going to check for sliding because their peak inspiratory pressures are so high. But
Sliding, you have sliding on the sides.
so gas or more acidotic or CO2.
Just chest X-rays current as well, by the way.
Peak could probably go down a couple more centimeters. I mean, I would push the tube down like 2 more centimeters. And this gas is after she was on the vent, right? So I would, well, toxic, it looks like she's retaining CO2. So let's increase her respiration rate. What's her minimum elevation? What was that? This one. I mean, I would increase the respiratory rate to maybe like 20 and see how that affects her CO2.
Relations rating about 6.5.
And then I want to increase the peak, but I don't know when I would do that. If her peak inspiratory pressure is so high. I mean, we can call ECMO, so you can call them and see what they think about it. So let's increase our peak to 8, or respiration rate to 18. And let's call TV surgery and inquire about ECMO, or at least put them on the radar. Put her on their radar.
Okay, how many calls?
Coming to 18. Date?
Yeah.
Okay. And then you want to call for ECMO?
Okay, you want me to call for ECMO?
Yeah.
Okay.
You have a patient with acute respiratory distress. You've been adjusting her ventilator settings.
Yeah, so this is the ECMO too?
Do you want me to talk to them or do you want to? Okay. Hey, we're just calling about a patient we have here in the ICU. She is ARDS-like picture, unclear exactly why, but she's currently on hypoxic, on PEEP of 8 and FiO2 of 100%. We're unable to increase her PEEP more due to her peak pressure in the 50s. Wanted to consult you for potentially ECMO.
So,
yeah, I mean, we know her pretty well. I mean, we're not crazy. I'm not crazy about recannulating her, especially when, I mean, we're only at a peak of 8. I mean, I see her 100%, but you're only at a peak of 8. I mean, I think there's a lot of things we can optimize here, so maybe we can optimize the ARDS first.
Okay, we'll call you back if we are able to make any improvements.
So let's start her on some, blood pressure is okay. So let's start her on some fentanyl. Let's start her on some propofol.
How much fentanyl, how much propofol?
So propofol, let's start at 10. And fentanyl, I would start it at 100 mics per hour.
100 an hour?
Yeah. That's gradient, yeah. That's not fentanyl. What is that?
2.
2. Well, my goal is I want to see if we give her a push of a paralytic, if that's going to improve her saturation, but I want to make sure she's pretty well sedated before I do that.
Might need a little more propofol.
Yeah, but I didn't want to like start her high and drop her pressures. How responsive is she, like, if I stimulate her? Like, what's her last?
She's negative, somewhere between -2 and -3.
Her, so let's put our levothyroxine, the leg dose. So like, let's see, 0.05 next to the other.
There we go.
Yeah, let's increase our fentanyl. Let's jump to 2.5. Let's get our blood pressure a little bit up, and then we'll increase our propofol.
And now 2.5.
Yeah. I'm going to start the levothyroxine. And then when her blood pressure gets a little higher, I'll increase her propofol.
Or increase at what?
0.05. Can we do another gas too?
The alarm's done. The vent's alarming at you.
What's it alarming?
Is she auto keeping or what does the waveform look like?
Do we have a picture of the waveform?
I mean, the waveform itself, there's nothing striking about the waveform itself. You got
So there are 2 beams. What's her plateau pressure with that? There are 2 beams like pink or anything like that. You suction it, you get like...
Yeah, question, there's nothing.
Does she look like she's fighting against the ventilator?
You could decrease her tidal volume and increase her respiration rate to like give littler breaths.
Yeah, but ultimately, yeah, we could do
Keep
that.
the
I want to
same
kind of
minute
increase the minute
ventilation.
ventilation a little bit more. So, the question is, do we want her to take slower, deeper breaths or faster, smaller?
I think faster, smaller. So you'll have less people.
But our issue is auto-keeping, right? Because if you're auto-keeping, you're making her breathe too fast and like, give her time to breathe out that pressure. So yeah, I mean, we could try, let's drop our tidal volume down to, how much does she weigh?
How much does she weigh?
Yeah, what's her ideal body weight?
She weighs 120 pounds.
Height.
She's 5'5".
Your current minute ventilation is 6.4.
What did you say her weight again was?
She's 120 pounds.
It's like 100 pounds ideal body weight?
So it's on height, she's 5'5", 65, so she's, her 6 cc's per kilo is 342.
Yeah, so let's put her,
But you can go as low as 4 if the plateaus are high.
yeah, but she's on 400 right now, so let's put her on 350 tidal volume. That's going to raise her.
This is the way if you want to see it.
If you want, do you want the same minute ventilation?
Yeah, at least.
If you
or
do
higher.
320 and 20, it's the same.
Yeah, so let's do 320 and rate of 20, tidal volume 320. Yeah, she's on.
Yeah, no, ours is the same.
20 to 320?
Yeah. She's on for a while.
Her,
What do you think?
You could
You're
probably,
under ventilating her too, like even on the settings we had her on before. So she's 719, she's got a metabolic acidosis going on too.
Yeah.
So you
We can
have
improve it a little.
to
Yeah.
overcompensate her a little bit because her pH is still 719. And then she's still hypoxic.
This one? No.
I
Oh,
don't
did I make the changes on here?
what's on? Yeah, you can do it. You can do that. And just.
What did we say?
320.
Something, if you're, some of these things I would, these are okay to look at, this pressure is okay to look at, these things don't necessarily agree with what I have going on, so ignore these numbers, this one's okay, these are okay. The waveform's also okay.
What's the lowest we can go down to? It would be 4.
And you could do 250 and 26. That would be the same.
What's her pressure? Let me go up on the lever side. Let's do 21.
A little better.
Well, I'm gonna see if we can paralyze it, but I want her blood pressure to be low. What's her rash?
-4.
Let's increase the propofol to
20?
Yeah.
Is that what you said?
To what?
20. Is she pretty responsive when I like stimulate her? Let's push on some rock.
Some what?
Some rock.
Okay. How much rock do you want?
Okay, cool. I don't know how much it's on there. Let's see. How much does she weigh again, kilos?
120.
That's
I
probably.
mean, 3 kilograms, I don't know. 120 pounds.
Let's do like 50 of rock.
Okay, so
How much are you giving?
50 of rock. So 50 of rock in and flesh.
Like 230 is like the lowest figure on how to learn.
Okay. Are her stats any better?
Not really.
Okay, so she might need to be paralyzed. Should we just start her on a paralytic grip or continue just to push as needed? I don't think there's a benefit either way.
Do you want to crown her?
Yeah, let's go there. Well, yeah, we could throw there.
Okay.
Alright, crown team, we'll do it.
We're gonna crown her.
Like in real life, we're gonna do this?
Are we gonna do you want us to actually crown her?
Is that what you actually want to do?
Yeah.
You do?
Okay.
Alright.
Well,
I've never done this before, so you just gotta tell me what to do. But I heard you needed help.
Alright, we'll let you know. Do we actually have pillows to put, or do you want me to just pretend we have pillows?
You want some pillows?
Yeah, I want pillows here, I want pillows here.
I will hold the easy too.
I have wedges. Will I
Nah, I can put it. Big wedges are too hard.
You can steal this pillow too, right?
Yeah.
This will be a pillow. And this will be a pillow.
Can you get this fork out there? And put it between the legs, please?
Uh-huh.
Let's take stock of our lines.
Yeah,
So we
hold
know
on.
what we have.
I'm gonna get it situated. So you're gonna roll over, we're gonna roll under.
I'm gonna roll under.
Yep, we'll roll it like this. With 2 sheets.
Oh, okay. Like this.
So we're gonna pull her up on the bed first.
Okay.
Pull her up, and we're gonna pull her towards you. Okay.
Towards me?
Yeah.
Okay.
1, 2, 3. So what we're gonna do first is we're gonna turn her towards me. So we're gonna put her on her side. We're gonna reach up to grab the top roll. With one hand, you're gonna reach underneath to grab the bottom roll.
Okay.
Once we each get it secure, then we'll kind of switch. We'll put both hands on top. You put both hands on the bottom. Okay. So 1, 2, 3. Lift up. Okay. Reach underneath. You got it?
Yep.
All right. Grab underneath. Grab underneath both hands. Tell us when you're ready.
1 second. Okay.
All right. Then the count of 3, we're gonna flip her. Into her stomach. Alright, 1, 2, 3.
Move her up this way a little bit. Or no, I got it.
You should have a donut for her head. And you kind of like move this underneath. Hold that down.
Under her head.
Still in place.
Okay.
Alright.
The fats are a bit better.
Alright. 94. Blood pressure is okay. Another EVG.
Where is there?
I would like to see her pH like at least 7.2. Her PCO2 71, so that's okay. What are her peak pressures?
Peak pressures are 45.
Still 45? Still just lactic acid. What's a repeat lactic acid? Can we send another one? I mean, it's still in between.
You've got a lot more room to ventilate too. I mean, what are we at 320 and 20, or are we 250 then?
Yeah, I
I
think
think
we're
we're now
good.
250 and 26.
Maybe we can go to increase this to 300 and see what happens. Our peak pressure still 45. What else can we do? Maybe that good.
Since you're asking the questions, we'll do it over time and we'll talk about this. So, give me a quick synopsis. So if I come through to, ask what's going on, tell you I'm bored, whatever, tell me what's going on.
So this is Janet Jackson, a minute a while. Yeah, Janet Jackson.
Yeah.
A minute a while ago, she was pregnant. She had massive PE, ended up being on ECMO, subsequently decannulated, then went into septic shock, was treated with antibiotics. The source of infection was a line. Most recently, we got consulted. She was hypoxic.
So they put in a line for the PE or for the sepsis?
No, she's septic.
She's not very. She's a little bit febrile.
Yeah.
Yeah.
She is. But they've been treating her with antibiotics. We recently consulted.
Is she on blood thinners?
She's on Lovenox, I believe.
She's on Lovenox? Okay, yeah. So, did she need to go for thrombectomy or?
No, they did ECMO.
What am I doing?
They're just like asking a bunch of questions.
I mean, so I'm a bit ADHD. I'm kind of all over the place, and so you're telling me what has happened previously.
Okay.
But what's happening now?
She looks like so right now she's an R. She's hypoxic. We intubated her, sedated her, started her on paralytics, and croned her. With all that, her sets have finally gone up to 94%. She still has like lactic acidosis, but her PO2 is improving, but her pH is still low. I would at least like to see like about a 7.2. We're still making adjustments on the ventilator.
Okay.
She seems to really kind of improve with sedation. We gave her a whole Civrop. Her peak inspiratory pressure has dropped down. We're able to prone her, and that improved her oxygenation significantly.
So on your problem list, what would you put as number one?
ARDS.
Number two?
Anion gap metabolic acidosis.
3.
I mean, I don't think she has a little bit of a
There's some good history to be aware of.
Yeah,
I agree. So I don't think you're wrong. I kind of bring those things. That my point there is I think that it can be tempting to tell the whole story, but she's got a long whole story.
Yeah.
And especially I just like to practice kind of getting to like, well, what's going on now. Very clearly is this. Right? Okay. So does this patient have ARDS? I mean, prove to me that you're right. Why can you make the diagnosis of ARDS?
So she has bilateral infiltrates on X-ray, which are new.
Good.
You know, we did an ultrasound. We don't, at least to me, it doesn't seem like it's cardiogenic in nature.
Okay.
She has a collapsible IVC, so she's not really fluid overloaded. What else is the Berlin criteria? So
Okay.
infiltrates, non-cardiogenic. Yeah, that's more for severity than actual. It's not more for like severity than.
Her beta ratio is like very poor.
Yeah.
So she's like 70.
Yeah.
One.
I say she's severe.
That's bad. Okay. So we definitely meet ARDS. What are our goals for ARDS?
So lung productive ventilation strategy. So
What does that mean?
So trying to keep our peak up below, our peak inspiratory pressure less than 40. If we
Peak
can.
inspiratory pressure less than 40. I don't know that that's. I don't know that.
So basically, it's like tidal volume is like 4 to 6 mLs per kilogram.
Low tidal volume. What is her current tidal volume? Where does that fit on the scale? 320.
I think it's like closer to 4.
That's like 600 was 342.
600 was 342.
We're high fives.
Yeah.
Okay, so we're meeting this. We're anywhere 4 to 6. We're about here. Other goals?
Can you do, I mean, stats like an 88 or above?
Or PO2 of
What is it?
5? 3?
Peak pressure is less than 30.
Again, I don't care about the peak pressures. Plateau. Okay,
Plateau.
plateau pressure. And
Not least.
Normal pH. Normal pH.
I don't know about normal
pH
pH.
should be like 7.2 or something.
Okay. So depending on who you're talking, I mean, I think the actual ARDSnet as it's written is like above 7.3, but we all know that like few people panic below 7.2, and some even go as low as 7.15. So if you pick any one of those, I think you're fine. Which one do you? Since this is your patient, which one do you want?
I would like to try to get at least to 7.2. If I can.
Okay. So, which one are we meeting in? Which ones are we meeting in? Which ones do we still have yet to accomplish?
So we're meeting 1 and 2. What was her peak for plateau pressures? Because I asked for the peak, but I didn't ask for plateaus. But I mean, they're definitely under.
So peak is 45. Whenever you check them, I'll give these to you as often as you ask for them, and if I miss it, then just hit me. The plateau right now are about 37.
So we're still not meeting that. And then we're still not meeting number 4.
Okay. So then, if I were to go through, I mean, if you look at the ARDSnet, there's actual pathways to this, and so I think that I guess the questions to ask ourselves is, what can we do to accomplish these? Recognizing we're good here, so far so good. What can I do to accomplish these yet not, disqualify those? I think that's where we're at.
Yeah. So I mean, we give her push paralytics, that seemed to work. I mean, we could start an infusion of paralytics. Let's see if that helps. I don't know if that would make a difference.
So when you push paralytics,
her oxygenation improved, her peak pressures improved. So I mean, I don't know that I've improved her plateau pressure. But
if I was going to pull up like the literature review of paralytics and ARDS, what kinds of metrics are they mostly going to be following and studying and those kinds of things?
None of them.
Like as far as like numbers of what we're looking at.
Would they be studying? So my question then is, so just to pick up for arbitrary reasons, like we have tidal volumes here. So if I just look up studies in ARDS and paralytics, does that have a bearing on like my tidal volumes goal? Does it have a bearing on my oxygenation? So you do, if I look up like paralytics, ARDS, would you see them talk about oxygenation, improving stats? Sure you would. Sure you would. Would you see paralytics in the zone for improving pressures? You would. I think, I mean, maybe it's just because I've looked for them less, but I see more studies looking for like paralytics for like refractory strategies for like refractory hypoxia, like as a rescue strategy. But I've seen it some for pressures as well. Would I see paralytics as a strategy to improve pH? Not necessarily. So I think of that more of like helping the SATs, fine, which we're doing okay with. Maybe a little bit with pressures. I think there's, and also in order to properly place things, so paralytics, is that a frontier method or is that like a rescue strategy? Hypoxia?
I think
More of a rescue, like desperate kind of measures because the data behind it is, it's not that fantastic, and so it's more of a rescue strategy. The data behind it is not fantastic. What about paralytics and things like reducing pressures? Is that frontline first thing we should reach for, or is that more like a reaching?
I think it's like reaching.
Well, more reaching. Okay, so what are the frontline moves we can make on tidal volumes? If we're too high or too low, then we move the knob. That one's simple enough. It's okay. So I took the easy one. Frontline things I can do if my SATs are low.
Again, changing your oxygen peak.
I got my FiO2, I got my PEEP, and then I got my rescue strategies. The best rescue strategy with the most data behind it, we've already done. And did it work?
Yeah.
Yeah, it looks pretty good. Okay. Frontline things I can do for my pressure. We've done one of them. And I don't want to say done. We've started on one of them. How about that? We've started on one of them.
So that like adjusting my settings every time I go.
Adjusting
What am I
the
saying?
volume,
Yeah.
You go as low as the full.
Good. So, I mean, what I'm trying to pull up here. I mean, if I were to pull up, so here's my pressures. I mean, this is straight from ArdsNet. And if I say that my plateau pressure is at go, if my plateau pressure is above 30, decrease my tidal volume by 1 milliliter per kilogram per hour, right? Until I'm down to 4. Straight from the cookbook. Okay. So there's definitely something frontline we can try. And again, we mentioned we are currently at where are we at our tidal volumes?
Around 5.
We're 5. So we've got room to go.
Yeah.
Thank goodness, right? I mean, because there's certainly going to be times when that's the right answer, but we're out of room and we got to like trade goals, and thankfully we're not there. Okay. What about strategies for pH? It's here as well. But I mean, I think you know without even looking.
Yeah, increased respiratory.
Increased respiratory.
We have around like 20.
What's our current rate?
20.
What's the max rate you can go on the ventilator?
like, I don't know, like
As far as the
30.
As long as you're not auto peeping.
Exactly, that's exactly right. It's variable, patient to patient. You can kind of get some more mileage if you adjust things like the flows and et cetera, but for most folks it's going to be somewhere mid to low 30s. So we've got room to go there as well. Okay. Game on.
Alright, so you said around 320.
You do like
Four
two.
is 2/3 essentially.
Yeah.
Yeah, so let's put it at 240 volume wise. And let's increase for
The rate would be like 27.
Yeah, so let's do 27 and 240.
27 and 240?
Yeah.
We were undershooting on that too.
Well, 240 is like
Like you were at 714. No, I mean like, so if you're adjusting your tidal volume down to 240, was that calculation you made to get us to where we are now?
Yeah, it's
And
the
when
same
then we were-
ventilation.
We were undershooting.
Yeah, I see.
So
You can
20,
do, like-
28 undershoots us still, or 28.
So let's see 30 and 240.
30 and 240 are the final answer? And where? Okay.
Well, what's the rate you would need us? It wasn't a plateau.
Plateau?
So we checked off number 3. And what I want to do for work with pH. So we check off 3 and 4. Calling it a day.
You want to talk about this a little?